Hello, everyone, and welcome back to the Unexpected Detour, where in life detours are inevitable. I am your host, Frances, breast cancer survivor, advocate, and someone who believes that understanding our diagnosis can remove much of the fear that often comes with it. Today's episode is a guided walkthrough of the breast cancer diagnosis journey. We're going to move step by step from the very first screening test to how doctors ultimately determine treatment. Many patients hear medical terms like mammogram, ultrasound, biopsy, staging, grading, and lymph node involvement, but the explanations can sometimes feel rushed or confusing. My goal today is to slow this conversation down so that it becomes easier to understand what each step means and how they all connect. The journey often begins with a mammogram. A mammogram is an X-ray of the breast used to detect changes in the breast tissue. It can reveal things that cannot always be felt during a physical exam, such as the small masses, clusters of calcium deposits called calcifications, or areas where the structure of the breast tissue appears different from normal. A mammogram does not diagnose breast cancer. Hear me that well. A mammogram does not diagnose breast cancer. Instead, it identifies areas that may need further investigation. Radiologists interpret mammograms using a system called BIRADS, which categorizes the findings and recommendations whether follow-up imaging or testing is necessary. If a mammogram reveals something suspicious, doctors may recommend additional imaging. This is where an ultrasound often comes in. An ultrasound uses waves to produce images of breast tissue. It helps doctors examine an area more closely and determine whether what appeared on the mammogram is a solid mass or a fluid-filled cyst. Ultrasounds can also evaluate nearby lymph nodes to see whether they appear enlarged or abnormal. However, like a mammogram, an ultrasound cannot confirm whether breast cancer is present. Imaging studies provide clues, but they do not provide a definite diagnosis. The only way to confirm whether a suspicious area is cancerous is through a biopsy. A biopsy involves removing a small sample of tissue from the breast so it can be examined under a microscope by a pathologist. There are several types of biopsies, including core needle biopsy, stereotactic biopsy, fine needle aspiration, and surgical biopsy. The most common method today is the core needle biopsy, which removes small cylinders of tissues from the suspicious area using a hollow needle. Once the tissue is removed, it is sent to the laboratory where pathologist examines the cells carefully under a microscope. The findings from this examination are recorded in what is known as a pathology report. The pathology report provides detailed information. Listen, detailed about the tumor. It identifies the type of breast cancer present, measures the tumor, and evaluates the characteristics of the cancer cells. One of the first things the pathology report identifies is the type of breast cancer. Some of the most types include invasive ductal carcinoma, invasive lobular carcinoma, and ductal carcinoma in STIU, STIT. The report also describes the tumor grade. Grades refer to how abnormal the cancer cells look compared with normal breast cells. Pathologists evaluate the appearance and behavior of the cells under a microscope to determine how aggressively they may grow. Grade 1 tumors tend to resemble normal cells more closely and usually grow more slowly. Grade 2 tumors show moderate differences from normal cells. Grade 3 tumors appear very abnormal and may grow a little more quickly. In addition to grade, the pathology report includes important information about hormone receptors. Breast cancer cells are tested to see whether they grow in response to hormones, such as estrogen or progesterone. If the tumor is estrogen positive or progesterone positive receptor, hormone blocking therapies may be used as part of the treatment. Another important marker is HER status. HER is a protein that can cause cancer cells to grow rapidly. Tumors that are HER positive may respond to targeted therapies, significantly designed to block that protein. Together, these markers help doctors understand the biology of the cancer and determine which treatments may be most effective. After the cancer has been identified and described in the pathology report, doctors determine the stage of the cancer. Staging answers the questions: how far has the cancer spread? Breast cancer staging is commonly described using the TNM system. The letter T stands for the size of the tumor. The letter N refers to whether lymph nodes contain cancer cells. The letter M refers to whether cancer has spread to distant parts of the body. The combination of these factors helps doctors assign an overall range ranging from stage 0, to stage 4. Stage 0 describes non-invasive cancer that remains within the ducts of the breast. Stage 1 through 3 describes cancers that involve the breast and sometimes nearby lymph nodes. Stage 4 indicates that the cancer has spread to distant organs such as bones, lungs, liver, or brain. A key part of staging involves examining lymph nodes, particularly those located in the underarm area known as axillary lymph nodes. These lymph nodes act as part of the body's filtration system and help remove waste and abnormal cells from lymph fluid. Because lymph fluid from the breast drains into these nodes, they are often the first place breast cancer may travel. During surgery, doctors frequently examine a specific lymph node, such as the sentinel lymph node. The sentinel lymph node is the first lymph node that receives drainage from the tumor area. Surgeons identify it by injecting a dye or tracer near the tumor. The dye travels through the lymphatic pathways and highlights the first node it reaches. If the node does not contain cancer cells, it is likely that the cancer has not spread to other lymph nodes. If cancer is found in the sentinel node, additional lymph nodes may be removed and examined. When lymph nodes are studied under a microscope, pathologists may describe the amount of cancer present using terms such as isolated tumor cells, micrometastasis or macrometastasis. Metastatic, yeah, metastasis. Okay. Isolated tumor cells are extremely small clusters of cancer cells. Micrometastatic refer to small deposits of cancer cells within the lymph node. Macrometastasis indicate large deposits of cancer cells. Another feature sometimes described in lymph node reports is encapsulation. Every lymph node is surrounded by a thin protective layer called a capsule. When cancer cells are found within a lymph node but remain inside the capsule, they are considered contained within the node. Sometimes cancer cells break through this capsule and spread in surrounding tissue. This is called extracapsular extension and may influence treatment planning. After doctors, evaluate the tumor characteristics, lymph node involvement, and staging information, they determine the breast treatment plan. Breast cancer treatment typically falls in two broad categories: local treatment and systematic treatment. Local treatments focus on breasts and nearby tissues. These treatments include surgery and radiation therapy. Surgery may involve removing the tumor through a lumpectomy or removing the entire breast through a mastectomy. In many cases, surgeons also perform a sentinel lymph node biopsy to remove additional lymph nodes to determine whether the cancer has spread. Radiation therapy is often recommended after lumpectomy to destroy any remaining cancer cells in the breast or nearby lymph nodes. Systematic treatments travel through the body and help eliminate cancer cells that have spread beyond the breast. These treatments include chemotherapy, hormone therapy, targeted therapy, and in some cases, immunotherapy. Hormone therapy is used when the tumor is hormone receptor positive, helping block estrogen or progesterone from fueling cancer growth. Targeted therapies are used when cancers have specific markers, such as HER2. Chemotherapy may be recommended depending on factors such as tumor size, grade, lymph node involvement, and the biological characteristics of the cancer. All of these factors, stage, grade, hormone receptor status, HER status, lymph node finding, and overall health, work together to guide the treatment plan. Before we close today's episode, I want to leave you with a few trusted organizations where you can continue learning more about breast cancer diagnosis, staging, and treatment. Reliable information can make a tremendous difference when navigating diagnosis. You may find helpful resources through the American Cancer Society, the National Cancer Institute, National Comprehensive Cancer Network, breastcancer.org, Living Beyond Breast Cancer, and the Susan G. Komen Foundation. I will include links to these organizations in the description of this episode that you can explore them at your own pace. Breast cancer introduces many unfamiliar words into our lives: mammograms, biopsies, grades, staging, lymph nodes, and treatment decisions. But when you begin to understand the language of diagnosis, the path forward becomes clearer. A little clearer, not all the way clear. We still got to ask the doctor. Knowledge doesn't remove the detour, but it can help us navigate with greater confidence. Thank you for joining me today on the Unexpected Detour. We continue to learn share, and support one another along life's unexpected paths. Because in life, detours are inevitable, but understanding can light the road ahead. Until next time, take care of yourself and each other.